Well, good morning, everybody. I'm Paul Johnson, Director of the IFS, and I'm really delighted to welcome you to this morning's webinar, where we're going to be talking about socioeconomic inequalities in the use of NHS care in England. I'm delighted to be joined by three distinguished speakers. First up will be Ben Zaranko, author of a report published yesterday on the use of healthcare in England, particularly by those over pension age, and Ben will focus in particular on the use of hospital care. We'll then be joined by Anita Charlesworth, Director of Research at the Health Foundation, who will look at inequalities in the use of primary care, and finally by Martin McKee, who is Professor of European Public Health at the London School of Hygiene and Tropical Medicine, and someone with a huge experience in public health. And he'll talk briefly, but particularly about the inequalities in COVID and the way that that has affected different socioeconomic groups. They'll speak one after the other for about half an hour between them. There will then be plenty of time for questions and answers, and you should all have access to Slido, where you can put your questions and indeed vote for other people's questions if you would like those to be asked. With no further ado, I will hand straight over to Ben, who will present on the recent report that he and co-authors have just published.
Thank you, Paul. So this was a research paper, came out yesterday. Myself and George Stoy at the IFS, along with Eric Brunner, Martin Shipley at UCL, and Martin McKee at the School of Hygiene and Tropical Medicine, who'll be speaking in just a moment. As I'm sure you're all aware, the NHS was founded many years ago on the principle that access to healthcare should not be based on your income, your age, where you live, your socioeconomic background, which should be based purely on your clinical need for that healthcare. But even if the NHS perfectly achieved that objective and ensured equal access for all, it doesn't necessarily follow that use of NHS care would be equal across groups. So it raises the question of whether individuals with similar health needs, so similar need for that healthcare, but from different socioeconomic backgrounds, use different amounts of healthcare on the NHS. And in this research published yesterday in the Millbank Quarterly, we've done an investigation into exactly that. So we've examined how use of hospital care in the NHS varies across different education groups among the older population of England. So we're going to be talking about healthcare inequalities. So to give a sense of what we mean by that, it seems obvious, but it's worth saying that individuals differ in how much they need healthcare. Some people are sicker than others. Some people are unfortunate enough to have illnesses and conditions that require extensive treatment. Others are more fortunate. We know also that average need for healthcare differs across different parts of society. So we know, for instance, that those with higher levels of education, with more formal education, are on average in better health. And so we'd expect them to have less need for healthcare, and so we might expect them to use less healthcare than those who are on average in worse health, and so we'd expect to see different patterns of use. What's interesting is whether those different patterns persist after you control for those differences in underlying health and need for healthcare, and that's what we're able to do. So we exploit this new data set that links individual level responses from the English Longitudinal Study of Aging, or ELSA, to those same individuals' hospital records within the NHS, and that allows us to carefully control for individuals' health status and how that varies, and also to look at detailed information about how much they use hospitals and what type of hospital care they used and when. And this is a large step forward in data quality and scope that allows us to go beyond what's been previously possible to answer new questions and to dig deeper into what's really going on. So the first half of this is the individual side. So we're using data from ELSA covering a 10-year period from 2004-5 to 2014-15. And we focus on those aged 65 and above, who are the heaviest users of healthcare in England. And that contains detailed information about their demographics, so their age and their sex and their ethnicity and so on, And also, importantly, lots of information about those individuals' health status. So they're asked to how they describe their general health. Is it very good, good, fair, or poor? They're asked if they've ever been diagnosed with 19 separate conditions, like have you ever had a heart attack? Have you ever been diagnosed with cancer, for example? And also lots of information about their numbers of difficulties with mobility or with activities of daily living, like getting dressed or washing themselves. So we have a really quite big, complete picture of how sick these people are and have a sense of their underlying need for healthcare, which we can control for in our analysis. And then we look across education groups, using education as a proxy for socioeconomic status. So we're going to split people into 3 groups. So the low group are those without any formal qualifications. The mid group are those effectively who completed school, so they have O-level or A-level equivalents. And then the highest group are those who have some form of higher education, for example, a degree. And if we look at just the raw data, how does health compare across groups? You can see here that those in the highest education group, 42% report being in very good health versus just 23% in the lowest education group. And those with no formal qualifications in that lowest group are much more likely to report being in poor health. They're also much more likely to report having a long-standing illness or limiting a long-standing illness than those with high levels of education. And those with low levels of education also report a greater number of difficulties with mobility and with activities of daily living. So what this paints is a picture of those in lowest education group are on average in worse health and on average have greater need for healthcare. We then link those individual survey responses to those same individuals' NHS hospital records recorded in the hospital episode statistics. We're going to focus on 3 broad types of hospital care. The first of those is accident and emergency. So care you get in the emergency department, perhaps after an accident of some kind or after developing some symptoms you want to get checked out. The second is outpatient care, where the patient is referred to hospital, most typically by a GP or by another hospital doctor, for instance, in A&E, but they don't have to stay overnight. And the third is inpatient care. So we're able to split between emergency admissions and elective or pre-planned admissions. These are where often the very sickest patients are. It's where the most invasive and extensive treatments are done and where a lot of the NHS spending goes. And if we again look at how use of these types of care vary across education, if we look at A&E, those in the low education group had an average of, in our sample, 0.3 visits in the previous year versus 0.21 for those in the top education group. There's less of an education gradient in use of outpatient care, and it's actually highest amongst those in the middle education group. Those with no formal qualifications have more emergency admissions on average and more elective admissions. So if we take total hospital care, it's clear that those in the low education group, as we saw earlier, are in worse health, and they also make greater use of NHS hospitals. But none of this controls for those differences in underlying health. So in our analysis, we're going to adjust for all that, control for all of that, and then examine how use of NHS hospitals varies across these education groups. So what I'm going to show you here is the number of annual visits for those in the middle group and the highest education group compared to those in the low group after controlling for their health and demographic characteristics. So a number of 0 would indicate no differences between groups. A positive number would indicate that those with high levels of education are using more NHS care than those with low levels of education but similar levels of health need. So splitting here between different types of care, you can see on the left-hand side that the more educated are using more outpatient care than their less educated peers. But there were no socioeconomic differences in the use of elective or emergency inpatient care or in visits to A&E, the emergency department. And we can then dig deeper within this and we look at how this might have changed over time. So we examine the period before 2010 and the period after 2010 separately. Looking just at outpatient care here, you can see that on the left-hand side, the coefficients aren't statistically different from 0. And on the right-hand side, you can see that clearly gaps emerged in the years after 2010. And those in both the middle and the high education group are having around 0.5 extra outpatient visits per year compared to those in a low education group of similar health need. That's equivalent to about 17% more outpatient visits per year than those with no formal qualification, so quite a substantial difference. To summarise our results more broadly, so we show that prior to 2010, there were no statistically significant differences between socioeconomic groups, but after 2010, some gaps emerged, and those with higher education are making about 17% more outpatient visits per year. That's driven almost entirely by different rates of use of routine care and follow-up care, as opposed to urgent care. So if we look at the number of referrals following cancer symptoms, for example, where you're supposed to be referred within 2 weeks, we find no evidence of socioeconomic differences there or in the number of urgent referrals. This is a story of routine care and follow-up care. That's where the differences are coming from. And there were no differences in the number of inpatient admissions to hospital. That's true of both emergency and elective in both periods. And there's actually some evidence that after 2010, those with higher levels of education used less A&E care than you might expect given their health need compared to the less educated. One potential reason why that might have occurred is that we know from previous work that those with lower levels of education make greater use of GP services and primary care services. And if after 2010 it becomes more difficult to get a GP appointment, for example, those individuals may have fallen back on A&E as a last resort. So we should be clear that the NHS does an admirable job of limiting socioeconomic differences in the use of inpatient care and urgent outpatient care. And that's to its credit, and that's in line with its founding principles. But we do find strong evidence that there are inequalities in the use of routine outpatient care that emerged in more recent years, at the same time as the pace of NHS funding growth slowed quite substantially. So this shows here the real terms growth rate in UK health spending over our period, and you can see that it averaged about 5% a year prior to 2010. After 2010, as a broad programme of austerity was imposed, health spending still increased, but only by about 1% per year. So the funding environment was much more constrained in the second half of the period. Now, further research is going to be required to understand better about what's exactly driving these differences, how they might be addressed, and precisely why it is that the gap opened up after 2010. But there are a number of potential explanations. So these include differences across groups in their ability to access care when services are being rationed in a period of austerity. So that might be higher educated individuals find it easier to navigate bureaucratic hurdles or to navigate informational barriers. And relatedly, you might see differences in referral behaviour from healthcare professionals. If, for example, highly educated and more confident and more eloquent, they can better make the case for why they need that extra appointment or better able to explain their symptoms. That might explain why they get more referrals. It's also possible that tastes and preferences for medical care or certain types of medical care differ between education groups. So even with equal access, they might just choose to use different amounts of care. So that might be less of a concern if that was what was driving this. Or it might be differences in people's ability to engage with and adhere to treatment once within the NHS system. So as I say, further research will be required, but it raises lots of important questions and hopefully will be useful for what follows. I'll now turn to Anita, who will talk more about something that was missing from our research, which is what's going on in primary care. Thanks very much.
Hello, I'm just double checking. See, can people see this video? Screen share. So what I'm going to do is pick up from Ben's presentation and talk about primary care. And I'm going to talk in particular actually about supply side factors. So Ben talked quite a lot about some of the demand side issues that might affect differences in use of healthcare. But the other thing that we know is important and have recognised since the start of the NHS is that supply side factors are also very important. And Ben's work finds obviously that there are differences in the use of outpatients over and above those who you would expect based on need, and access to outpatients is principally via referral from a GP. So what's happening in general practice also seems important. But just to emphasise before I go into GPs, some of the real strengths of the NHS in relation to access based on need rather than ability to pay. So the World Bank collects a series of data on out-of-pocket healthcare expenditure. And as you can see from this, the proportion of people who are spending more than 10% of their income on out-of-pocket healthcare charges in the UK is very low. And much lower than many other countries in Europe as well, where you might not think of that. The number of people who skip a consultation due to cost is also so very low. So if there is a reason, if we're seeing differences in use of services for associated with socioeconomic status, cost doesn't seem to be the main reason for that. So again, prescriptions, where we do have prescription charges in the UK, even though, obviously with a tax-funded NHS, again, as you see, even with a system of prescription charging, there are very few people who skipped a prescription medication due to cost compared to other countries. Not trivial, obviously, there are some people who are skipping that, but comparatively few. So cost is not the barrier. So the question then does come, what might be? And we've known since the start of the NHS that when the NHS was founded, obviously it did focus on that demand side, taking cost away as a barrier to using healthcare based on need. And that was the founding principle of the NHS. But actually on the provision side of the NHS, we took into the NHS a legacy of hospitals in different geographies and provision of care, patterns of doctors' practice, which were heavily influenced by a period where cost had been an issue. And one of the things that's been really challenging over the more than 70 years of the NHS is to bring the supply of healthcare geographically into line with need. And since the 1970s, we've had a system of resource allocation that's tried to shift money and resources to communities that have the greatest need for healthcare. And in general practice, the funding formula for general practice, which has something called the Carr-Hill formula, has tried to incorporate need for care within that. So, but even despite those many years of efforts, what we see actually in some recent work that we've published at the Health Foundation is that we've got quite a long way to go in terms of making sure that the supply of primary care is well aligned with need. So this first chart shows you, so here we've grouped geographical areas, lower super output areas, so that's about communities of about 5,000 people, I think. We've grouped those into from the most deprived, which is the red line, to the least deprived, which is the bluey-green line. And what you see here is that when we look at payments to general practice per patient by deprivation, that actually the payments, GPs in least deprived areas receive more funding. So that's the opposite, I think, of what you would expect based on what Ben was talking about. We also see that once we just for need, that actually those most deprived areas have fewer GPs per head of population. So if you adjust for need, practices serving the most deprived populations receive 7% less funding per patient than those serving the least deprived. And there are fewer GPs then serving the least deprived. But skill mix in those communities is different. And what we see is practices in the most deprived areas having more nurses. So again, the red line is the most deprived. We also see then that actually the number of appointments overall is not that different in between the most deprived and the least deprived. But what is different, very much reflecting that difference in supply, is that in the least deprived areas, you're more likely to see a practice nurse than you are to see a GP. Now, that may be important for referral to outpatients, because it is normally GPs who would be doing the referral to outpatients. So that skill mix may be well suited to some types of need, but may provide less access to hospital care. Yeah. The other thing, which is perhaps quite important, thinking about COVID-19, which Martin is going to come on to talk about, and whether access to care has been based on need through this very difficult period at the moment, is that we see a different pattern in the way that people use primary care between better off and worse off areas. So what we see is that the most deprived have more face-to-face appointments. This is all pre-COVID, it runs up to December 19, and less use of telephone. Now, obviously, what COVID has done has restricted access to face-to-face appointments and shifted much more of primary care to telephone or online contacts. Overall, use of services, primary care services fell during COVID, but there was this big shift in the route to access. And I think one of the things we really need to think about is and look at is whether those in most deprived areas who were previously as well more likely to use face-to-face and less likely to use telephone have seen their access particularly restricted during this time period, and then most critically, what impact does that have on health? So of course, differences in supply only really matter if they affect quality. So some of those issues about different models of care may be better or worse. We can't fully judge. If we look finally then at some of the measures of quality of care that we have, we certainly see that the Care Policy Commission that rates GP practices finds that there are fewer outstanding GP practices in areas of deprivation, more inadequate, and more who are in the category of requiring improvement. And finally, we do see that patient satisfaction is lower in the most deprived areas. Patient satisfaction with primary care is falling across the board. It is falling most in deprived areas who were already had the lowest level of satisfaction. So I'll hand over now to Martin.
Okay, I hope you can see the slide there, and I'm going to say a few words about COVID and the way in which it is weighing unequally on people within society in the United Kingdom. I'm going to run through it quite quickly to look at who is at greatest risk of becoming infected with COVID-19 and why, who is most likely to die if they're infected, who suffers most from responses to the pandemic, and are we doing enough to protect them from both illness and the treatment? So who is at greatest risk? Well, as you might expect, and as you probably have gathered from the media coverage, we find that certainly in the early stages of the pandemic, and in fact it has continued, that the incidence of infection is highest in among the most deprived groups in society. Although this is the number of positive cases, because it is displayed by quintile, it can be interpreted in the same way as being a rate. So you can see it rose most rapidly among the most deprived groups and least among the least deprived. Why would this be the case? A number of reasons. This is taken from a paper by Claire Bambra. Increased vulnerability with people in the most deprived areas having pre-existing health conditions or more likely to have them. Increased susceptibility with immune systems weakened by adverse living and environmental conditions. We've known for a long time that that can play a role. But particularly important is increased exposure. People who have working conditions that place them at risk. We know that lower paid workers, especially in the service sector, are much more likely to be designated as key workers and have to go to work and to be working in public facing roles. They're more likely to have to travel because they're less likely to be able to work from home, and they're more likely to live in overcrowded multi-generational households. So given that people in more deprived areas are more likely to be infected, who is most likely to be admitted to intensive care units? And here we again see a very stark association between where you live and your probability of being admitted to ICU. Many of the factors that lie behind this are the same as the ones we saw on the earlier slide. The next question is who is most likely to die? This slide shows in blue and green the death rate from all causes, age standardized, and in black and a sort of greeny yellow, the death rates from COVID. And again, you see a socioeconomic gradient all the way through in both. The point that this makes, I think, is one that David Spiegelhalter has made repeatedly, in that in general, what COVID is doing is increasing the probability of death by a proportionate amount among all ages, but also among people. It's increasing the risk that you would die from anything, as well as the risk that you would die from COVID. But here we can see a steep gradient all the way through. We can look in a little bit more detail, not just at level of deprivation, but at occupations. These are data from ONS, and they're showing that people in professional occupations are much less likely to die. People in what they call elementary manual occupations are more likely to die, as are those in the caring and leisure and other service occupations, of course, which make up a high proportion of people in the more deprived parts of the country. We can look in a little bit more detail and see, in this case, just as one example, that there is a particular risk for those who are in public-facing roles. Large goods vehicle drivers don't particularly have an elevated risk, but taxi drivers, cab drivers, and chauffeurs do have, and this is entirely what you would expect to see. Similarly, bus drivers, but to a lesser extent than taxi drivers. And this is simply a function of proximity and the duration of time that you're with other people who may be infected. And again, something that has attracted a lot of attention is that there is a much higher death rate among some Black and minority ethnic groups, in particular people of Afro-Caribbean background and Bangladeshi and Pakistani background. So in all of these, we're seeing that groups that are vulnerable in other ways and are more likely to live in deprived areas are at greater risk of being hospitalized, being in intensive care unit, and dying. I want to move briefly onto a rather complicated slide. It's from a paper that we published in the British Medical Journal. Margaret Douglas was the lead author on it. We published this at the very beginning of the pandemic, and it's an attempt to look at the pathways by which the responses to the pandemic can impact on health. Of course, the infection has a direct role in killing people, but home isolation has consequences, particularly in areas like mental health, substance misuse, online gambling, and so on. Restrictions in health, in education, in transport have implications, and we have a whole series of consequences, physical inactivity, family violence, access to basic necessities, debt, housing insecurity, and so on, all of which contribute to the indirect effects of the pandemic. So we need to be particularly careful there. When we look at where the restrictions are being imposed, we can see that they are in many of the most deprived areas of the UK. There, of course, are other factors to take account of here, because there are areas, as has been pointed out to the Prime Minister, given the high rate in his own constituency, there are places that are not being locked down that also have high rates. But you can see here this double burden, very high rates of infection in parts of the Northwest and the Northeast, coupled with the impact of the lockdown. Are we doing enough to protect people from both the illness and the treatment? This report from the coronavirus mental health and the pandemic study, I think, is particularly helpful. It points out that twice as many unemployed people say they're not coping well with the stress of the pandemic compared to people in employment. 1 in 10 people say, unemployed people say, that nothing has helped them to cope with the stress. And again, there is a wealth of data in this report. While the overall picture for many is improving, and we've seen how billionaires have done particularly well in the pandemic, a third of British adults are worrying about their finances, and almost half of people surveyed who are unemployed are worried about having enough food to meet their basic needs. Now, I think what this shows in a slide that was inspired by comments from my colleague John Edmonds on Newsnight last night is that the virus is actually shining a light on the existing fractures within the British society. All of these inequalities have existed for a long time. We've known about them. And interestingly, when we look at other countries that have much stronger social safety nets, like the Nordic countries, leaving aside the rather bizarre policy in Sweden, but in the Nordic countries more generally, what we're seeing is that with strong social safety nets, there is a high level of protection from both the virus and from the consequences. What do we need to do? Above all, we need to control the pandemic. The only way out of this is to get infections as low as possible. Zero COVID doesn't mean no infections. It does mean that when outbreaks occur, they are clamped down on very quickly with very effective find, test, trace, isolate, and support systems, with a particular emphasis on support for those isolating. We know that less than 1 in 5 people who should be isolating are doing so. We're not blaming them because they get very little support, and in particular, those who are in the gig economy find it particularly difficult. But above all, when we do impose restrictions, it should only be to buy time to put in place well-functioning testing, tracing, isolating support systems, and to put in place things like ventilation and other precautions that will allow us to build back better and to learn from this pandemic. Thank you very much.
Well, thank you all very much for those amazing presentations. For people who are watching, please do ask questions on Slido. We have a couple to kick off with. One very specific one for you, Ben, which is a question from Mohammed Amin. And the question is, do the outpatient visits you include in your data include diagnostic testing? Because that might be the case that high status individuals are more likely to have routine blood tests, for example.
Yeah, so as we've shown, the differences are in those sorts of routine appointments. Lots of them will be for like lab tests and diagnostic tests and that sorts of thing. Which, yeah, may perhaps Mohammed doesn't find that too surprising, but it's still important to document and show that it exists. And I think that the key thing that I took from that personally was that if the differences in use of NHS care are in those sorts of, yeah, maybe it is the routine diagnostic tests, but those are the sorts of things that help you catch diseases earlier and catch illnesses earlier. And if those things do systematically differ across socioeconomic groups, that could contribute to the broader inequalities in health that we do observe, and that then contribute to what Martin was talking about in people's pre-existing vulnerability to COVID and so on. So I hope that adequately answers the question. And if you, Anita or Martin, have anything you might want to add?
Just one thing to reflect on, which is, I think some of the incentives for better off people to use routine outpatient care changed over the last 20 years. Waiting times fell significantly, and the government introduced access to things like hip replacements done by private hospitals, but paid for by the NHS. So we saw a shift from people using entirely private pay systems to people for some of that more routine care moving into the NHS and getting that care funded by the NHS. You can't access things like a hip replacement without going via the outpatient system on a planned basis. So also it's worth saying that the balance between private care and NHS care shifted through that period due to changing incentives, I think, for better off people to use the NHS for some of that planned care. So some of them were using the NHS more, whereas they were previously potentially substituting NHS care for private pay, often insured.
Yeah, if I could add to that, actually, then there's two things that spring to mind. First of all, is there is evidence, we know that when waiting times fall, demand for private health insurance also falls, more people do switch back into the public sector. But then I should also then say that in the work that we've done, we are focusing purely on use of public healthcare. And if those same high education, wealthy individuals are using private healthcare that we can't observe, the education gradient in use of total healthcare would actually be more stark. And so we might be understating the true differences in how much healthcare these people receive. We're just focusing on the public element of that, the NHS element of that. But it's important to bear that in mind throughout, that we're only capturing a big part of it, but not the entire picture.
Yeah.
Question for you, Anita. I mean, I just wonder whether you could just run through again why it is that you get this, I thought, remarkable result that GP per patient funding is lower in more deprived areas, given that, as I understand it, is not the intention of the formula by which money is distributed.
Yeah, so I think it partly is there are two factors. I think one is that I think there's a lot of concern that the formula is out of date and underweights for deprivation. Now the formula only applies to a portion of the funding. So the way that GPs get their funding is there's a large amount of the funding comes via a formula per head of population. It's what in the jargon is called a capitation payment. So GPs get paid to provide care for an individual, whatever care that's needed over a year, recognizing the fact that older people use more care, people in deprived areas are more likely to have high need, as Ben is talking about, they'll need more care. It waits for those things. So one problem is, does it wait enough for deprivation? The second thing is, though, that alongside that core of capitation funding, there are lots of other pots of funding. So there are things called the QOF payment, the Quality and Outcomes Framework, which links to certain activities that GPs do. Have they checked everybody for, are they following the right pattern of care for diabetes, things like that. Yeah. In deprived areas, they tend to do less well on that QOF system. So it incentivizes higher quality, but the GPs in those areas seem to struggle with that. There are payments for things, enhanced services, extra services that GPs can provide. All those things, I think, seem to happen less in practices who are in deprived areas. One of the reasons for that may be that practices in deprived areas are much more likely to be very small and single-handed. And lots of these other payments tend to be easier to get if you're in high-quality premises, purposeful benefits, in big GP practices that can organise it all and have the whole range of staff that you need to deliver that. So you get this sort of, and we often see this with prevention measures as well. You know, the aim to improve the quality of primary care and the range of services, practices in better off areas have been more able to take advantage of those opportunities than practices in deprived areas. And so it may have improved the average, but it's also probably extended the distribution in an unfavourable way. And this is a very common thing in healthcare.
Yeah, that's thanks for that, Anita. That's really really interesting. I think there's one here for Martin, which is essentially asking about the longer term consequences of COVID for inequalities. I mean, do you think that this will create longer term inequalities in access to other forms of healthcare, given what we know about the number of cancelled operations and so on? Will waiting times increase more, do you think, for the more deprived?
Well, there are two aspects to this. The first is that we're only now beginning to understand the long-term consequences of the disease itself. Some evidence, for example, from the COVID tracker run by Tim Spector is suggesting that perhaps 10% of those infected, in a way that is actually unrelated to the severity of the initial illness, could have this condition that's being called long COVID. This is a disease that has, I mean, we unfortunately focus just on cases and deaths, but there are a lot of people who are living with severe consequences. Three elements to it. One, those who were in intensive care, that can take about a year or more to recover from if you've been on a ventilator. Secondly, the more general post-viral illness syndromes that have been talked about for a long time. But third, growing evidence that there are quite specific effects of this due to the increased inflammation of the blood vessels, damage to the lungs, and particularly to the heart. A number of high-profile accounts of sudden death in young hyper-elite athletes in the United States in particular. So I know that a number of trusts are looking at setting up special clinics to look after people with this in the longer term. So I think there is a real concern about that. But the other issue is the immediate effect on on waiting lists and so on. And the difficulty is that just from simple mathematics of queuing theory, we know that if you do build up a backlog, it can take a very long time for it to clear. I mean, we just see this every day if you're driving on motorways where people just slow down a little bit and you can very quickly get a 10-mile tailback. So it's going to be very important. But I think what we need to do there is to look at what other countries have done in the aftermath of SARS, because these things, first of all, the virus will be around for a while, maybe for a long time. And secondly, we don't want to be in this position ever again. So if you look at Singapore, for example, the way in which they built their hospitals to have two different pathways, one for people potentially infected and one for people they were more reassured were not, and to have more, to build the facilities in ways that do have more negative pressure room, they do have more facilities for isolation and so on. The challenge that the UK will have in this is that, of course, much of our hospital capacity was built using PFI deals, where the cost of introducing modifications is extortionate. And I think there will be a challenge there. So if hospitals and other health facilities are going to put in place the new design features that were incorporated in countries in East Asia, South and East Asia in particular, I think we may have to look at that financing model, because it could be a major barrier to doing the things that we need. But that's another issue. But I think I would concentrate, I think we need to look at both the implications of long COVID, which could be very substantial from what we're seeing, and also the consequences of clearing the immediate backlog. Both are important.
Thank you. Anita.
Yeah, couple of things on that worry me from a inequalities point of view. One of the last points I was making in my presentation is really making sure that the move to digital first and triage via that doesn't negatively affect on inequalities. And obviously the expectation is that primary care will now, going forward, be predominantly a service that you access via the telephone or the internet, and face-to-face is only where necessary. So digital inequality, the digital divide, becomes incredibly important there. But also, actually for A&E, the expectation is that we're going to move to a system where no one walks into A&E anymore. You come in via two routes: either you've rung up and they tell you to come in, or an ambulance collected you and it took you in. So again, the access to and ability to properly utilise, which is as important, those different routes in, will be really important going forward. The second thing I wanted to talk about and pick up on was some of the points that Martin made in his slides about mental health. And because I think one of the ways in which we could really exacerbate the impact of COVID-19 and lead to long-term scarring effects for health and all social outcomes if we don't quickly address the growing burden of mental health. We know that obviously this has impacted people with severe mental health, and many of those have got worse. But the biggest impact is probably the shock to people's lives will lead to elevated levels of depression and anxiety. If they're treated early and well, and there's the social support networks and all the things that Martin was talking about, we can make this a horrible year to have lived through, yeah, but something we come out of. If we don't make access to those services readily available, then we turn a short-term real crisis into a long-term disaster for those individuals. And so, and the problem at the moment is an awful lot of attention is going to hospitals, rightly so, they matter, yeah, but much less attention is being paid, I think, to the critical role that mental health services will play in determining how long the after effects of this pandemic will be.
Yeah.
Moment. Yeah, but I think that's and that will compound inequalities in really significant ways. And this is an IFS website. We know overall mental health. You've done all the work on households below income and all of that. Mental health is so important now for attachment, or more to the point, detachment from the labour market, to all manner of long-term outcomes. Not health.
Maybe just to add to that, I think we also need to really look at the lessons from the global financial crisis and the role of active labour market programmes, supporting people back into work. We have a wealth of literature which we and others have contributed to, looking at the way in which some countries were able to mitigate the impact on mental health of the financial crisis and others were not. So, for example, in Spain, as job losses went up, so did suicides. And as they came down in parallel, whereas in Sweden, there was a complete disconnect. Suicides continued to fall all the way through despite job losses. There is a lot there about retraining, about supporting people back into work. And unfortunately, it's not clear that we're learning that lesson in the United Kingdom.
Yeah, I think that's really important stuff. I just draw attention to two other IFS studies, actually, which relate directly to this. One is some work we did earlier this year on the mental health consequences directly of the lockdown period, which showed a huge increase in the fraction of people reporting significant mental health problems, and particularly among the young, and particularly among young women. And that's a study that's up on our website under the coronavirus banner. A second was a study that we carried out looking at the long-term consequences for health of the financial crisis, which showed a very large increase in the number of people with long-term health problems associated with the period of unemployment after that crisis, particularly mental health problems, but physical health problems as well, which is probably a good moment to reflect on another question here, which is really asking quite a broad question, which is how all of this analysis compares with what Michael Marmot's been doing for so long on socioeconomic determinants of health inequalities. Again, Martin, do you want to pick that one up first?
Well, it really reflects the point I made in that slide where I said that COVID was actually shining a light on existing fractures within society. The inequality, I mean, there are some specific elements in that people who are in public-facing roles are particularly vulnerable. Taxi drivers, for example, care home workers, and so on. But generally, the inequalities that we're seeing are exactly what we're seeing more generally in society. And I think what's important here is that when we look at some of the countries that are doing well, I did make the point about the Nordic countries. You know, people talk about Sweden without really understanding what's happening there. Sweden has, we can only look at Sweden in comparison to its neighbors, where you've got a high level of social protection in all of these countries. And Sweden, of course, has done far worse than Denmark, Norway, or particularly Finland. But having all those social safety nets in place in the other Nordic countries have really helped them to reduce the direct and the indirect burden of disease as a consequence of all of this. And I think when you see a society that is built on the gig economy, on precariousness, which we haven't talked enough about, again, something that we've looked at a lot in the context of the global financial crisis, the fact that the UK has a lot of people who, even if they're coping at the minute, are just one step away from loss of income, employment, housing, and in some cases even adequate food. That's a key issue which directly feeds into mental health, which we could talk a lot more about that. But I think we're just shining a light on the existing problems.
Did you want to add to that at all, Anita?
Yeah, I think it's quite an important thing for us to think about, even, with that, I agree with all that Martin said about COVID, but I think it's one of the things that we really need to reflect on, in that obviously, the NHS free at the point of use is a really important principle to protect people from catastrophic costs and to support their health. But actually, 70 odd years of an NHS, and then you look at the Marmot figures and you look at the sharp gradient in life expectancy and the even sharper gradient in healthy life expectancy. And you realise, however brilliant we make the NHS, however far we deal with all of the issues that Ben has identified in his study about access to care, actually the most important thing for a society is ensuring that people are healthy and live long, healthy lives. The NHS plays a part in that, but it's only a part. And we shouldn't assume, because we've got an NHS that we're really proud of, that it's job done in terms of health inequalities. That NHS sits in the context of your social and economic determinants of health. And for whilst we can hold our head up high globally and be proud of the NHS, our social gradient in the social determinants of health is worse than many other countries. And so actually after all this time with an NHS, it's still the case that for people in the lowest income groups, their healthy life expectancy is less than 60. In fact, for the most disadvantaged, it's less than 55. That's over a decade before retirement age, where people are living with ill health. And in many areas, we're getting worse. So, life expectancy improvements stalled from 2011. And for some groups, in particular, women, deprived women under 50, life expectancy is going backwards. By any measure of society's success, life expectancy for groups going backwards is pretty damning. Yeah. So the NHS is good, but it's not job done as part in terms of the nation's health. It plays a small part. It could do better, as Ben has suggested. But sometimes you worry a little bit that almost as a society we think we've got the NHS, so we don't have to think about these other things.
If I could just add to that in a very IFS-esque way and look at what the government spends its money on and how that's changed. If we think about the broader social determinants of health that you were talking about, Anita, it's striking that we've increased spending on the NHS in real terms by historical standards, not particularly generous amounts, but it's still heading upwards. At the same time, we've cut spending on local government services, social care services, parts of the justice system, probation, working age benefits, all those other things which might play a role in determining people's health. And I think that if you do want to focus and zero in on those broader social determinants, you have to think also about where government resources are going and how much they're focused on the NHS. And even within the NHS, I think you two of you talking about mental health services. Yeah. There's a world where in the years to come in the NHS, in response to COVID, resources are increasingly allocated to hospitals in the acute sector, and things like mental health services get squeezed, which is something we've seen historically, and there's been signs that they want to reverse some of that, but there's a world where that happens again. And I think we need to think not just about how much spending we do on the NHS versus everything else, but also what the NHS spends its money on.
Yeah.
Could I just add to Anita's point, because I think this point about this noting that life expectancy has been going backwards for some groups in society. Now, Lou Hyam, Danny Dorling and myself have written quite a bit about this and been heavily attacked for raising it, for making the point, and people find lots of other excuses or, well, you're too early to say, and so on and so forth. But if we look historically, this really should set alarm bells ringing, because this does not happen outside wartime. And the few examples where it has, like in the 1980s in the Soviet Union, where they presaged major political crises, Now, we've also shown, for example, in the UK, that where mortality was, the areas where mortality was increasing were the areas that voted for Brexit. Jacob Bohr in the United States has shown that declining life expectancy was associated with a shift from the Democrats to voting for Donald Trump. And so you can see that these worsening conditions fuel populist policies. And unfortunately, many of them will make life worse for the people who are worst affected. So you can easily get into a vicious cycle. So I think this should have really set us thinking much earlier and taking it much more seriously. And it's deeply worrying that we haven't.
Again, to draw attention to other work going on at the IFS, we're running a very big piece of work looking at inequalities in the UK, which is being run by Angus Deaton, the Nobel laureate, who has also written a lot with Anne Case about what he calls deaths of despair, which is his work so far has been really focused in the United States, where deaths of despair are effectively those that result from suicide, alcohol, or drug-related problems, which have been going up, particularly among low-skilled middle-aged men in the US, and particularly in those areas where there have been big increases in unemployment. We've been looking at similar issues in the UK, and whilst it's on nothing of the scale that it's in the US, it is nevertheless an issue which is increasing among exactly those groups, men in their 50s in deprived areas, and you are seeing for those particular groups increasing rates of death. We published something on that, and we've got more to come relatively soon. Just one final question before we run out of time. Do we know anything about, this is quite a big question for 2 minutes, do we know anything about access to the NHS by ethnic group? I mean, are there additional problems about access for different ethnic groups on top of those which are linked to socioeconomic status? I don't know which of you would be, only one of you can have a go. Who's going to jump in first?
Andy, did you look at?
I can say to start with, we in our sample, there's not, particularly the older population in England, there's not, and the sample sizes we've got, it's not enough people really to say anything meaningful. So it wasn't something we were able to look at. I agree that it's extremely important and it's something we'd like to look at in future, but in this particular study, it wasn't something we were able to do.
Martin, Anita, is this something you have any?
I think we can say categorically it's an under-researched area, because for a very long time, the NHS collected very little data on ethnicity, which made it quite difficult to study. I think COVID, one of the positive upsides of COVID-19, you have to look for silver linings, is it has absolutely shone a light on that domain of inequality. And there's a lot of work going on to try to identify that. I also think, Paul, in thinking about the work on inequality going forward, what a lot, I think, to date has looked at the impact of men, and Deaton's work is right that you find that. One of the things that obviously is happening with COVID-19 is that it's impacting very heavily on women in the types of jobs and labour markets, and we also know that actually the UK has been getting better in terms of health outcomes for men, but we trail internationally for health outcomes for women, and we don't talk about that very much at all, actually.
Okay. Well, thanks very much for that. We are now at the end of our allotted time. So thank you all for listening. Thank you very much to Ben, Anita and Martin for a great event. Do keep looking out for IFS events. We have another one just this Friday looking at changes to the welfare system relating very directly to these issues of inequality that we've been discussing. And then again, next Tuesday, we're launching our annual green budget, looking at the more general state of the public finances, even though the Chancellor has once again rather rudely cancelled the budget. So thank you all very much and hope to see you all again soon.
Thank you.
Thank you.